All right, I'd like to welcome Dr. Olivia Kim-McManus to the stage to talk about her experience with her patients treated.
Hello, good morning. My name is Olivia Kim-McManus. I've been treating one of the n-Lorem patients for a while now, and I am happy to be here to talk to you about channelopathies in the space of ASOs. From my impact perspective, 3.4 million people are diagnosed with epilepsy in the United States and 65 million worldwide. 150,000 people will be diagnosed with epilepsy this year, and 30% will be medically intractable, meaning that seizures are uncontrolled despite 2 or more seizure medications. And at that point, your chances of seizure control are less than 10% with standard approaches. And so epilepsy is one of the most common chronic neurological conditions of childhood with high morbidity and mortality, including increased risk of Dept. Here's an example of EEG, electroencephalography, in a patient with a genetic variant shown with remission, in which you see the EEG running electrographically. The seizure has already started, and this is a clinical manifestation of a channel disruption. And so the clinical features are arousal from sleep with focal head turn to the left, followed by bilateral tonic-clonic activity. And so these seizures often affect many patients with channelopathies and can lead to significant morbidity and mortality. Epilepsy is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And so you can imagine that medically refractory epilepsy is often due to genetic causes, and channelopathies are a significant cause. Intractable epilepsies are often single gene mutations and monogenic. Many are de novo, and many are mediating neuronal or cell signaling pathways, and so these are really opportunities for genetic interventions such as ASOs. Really, the neurophysiology of channelopathies includes a complex cellular and network interaction, both between excitatory and inhibitory neurons and interneurons, resulting in neurotransmitter activation for excessive membrane depolarization. And so there's different channels that are involved, including the metabotropic ligand-gated channels that are glutamate or GABA, or ionotropic voltage-gated channels such as the SCN sodium or calcium-potassium channels. And across the board, even though there's single variants in these genes, monogenic variants, there's broad phenotypic manifestations. We've been talking about this all morning in terms of how there's many symptoms of overlap despite the etiology, but we really want to look at the etiology and the cause of these symptoms, which present often in channelopathies with seizures, developmental delay, which includes the language and motor categories, autism, movement disorder, ataxia, cerebral palsy, and dysautonomia, to name a few. And so there are existing FDA therapies and INDs that provide new opportunities for really specialized and targeted therapies. We want to tailor your individualized therapy from the molecular to the network level, and that includes with a genetic diagnosis. If you know a variant that you know it mediates a certain channel, that will help you tailor and optimize the appropriate anti-seizure medication selection. That is already existing, may be tailoring you towards epilepsy surgery with neuromodulation, but knowing that you may or may not be able to remove certain anti-seizure medications, and then allows you to explore additional options that are more cutting edge, like ASOs. And so developmental and epileptic encephalopathies are a category of developmental disorders that include seizures and neurodevelopmental difficulties. 1 out of 6 kids in the US are diagnosed with developmental disabilities, which include the developmental and epileptic encephalopathies. In California, between 2020 to 2021, over 75,000 children from birth to age 2 were eligible for early intervention by Regional Center for Developmental Delay and Disability, and those are just the ones that are known and diagnosed. Developmental epileptic encephalopathies, or the DEEs, have a known incidence of over 1 in 2,000 live births, and really collectively are more common than well-known genetic conditions like cystic fibrosis and spinal muscular atrophy. But there's hundreds of known monogenic causes of DEE. And so really the individualized therapy is required for some subtypes because of this genotype-phenotype heterogeneity. When we look at developmental and epileptic encephalopathies, or the DEE, cognitive functions are both influenced by the seizures and the neurobiologic underpinnings of the channelopathy. And so onset is typically early childhood. It can be infancy, day of life 1. Many are related to the causal gene variants. And so neurocognition itself can benefit from precision therapeutics targeted to the underlying genetic mechanism. We've been talking about SCN2A, and it's a complex sodium channelopathy. NaV1.2 channel is highly expressed at the nodes of Ranvier and axon initial segments early in development, and gain of function with abnormal early action potential generation will lead to neuronal hyperexcitability. Phenotypic complexity includes seizures that are often medically refractory, hyperkinetic movement disorders, abnormal muscle tone, including hypotonia, intellectual disability, autism spectrum disorder. It's a significant cause of autism, GI issues, and autonomic dysfunction. SCN2A related disorders is an example of significant variability within the gene. There's over 90 different variants. And so missense variants, it's important to characterize the variants. Missense variants are often gain of function, present with early infantile epilepsy, less than 3 months of age. Protein truncating variants or splice site variants are often loss of function or mixed function with later onset epilepsy, intellectual disability, autism with or without epilepsy. And so there's major implications for the design of therapeutics, whether you're talking about anti-seizure medications that are sodium channel blocker drugs like phenytoin, which we were discussing earlier, and targeted therapies. So in context of what's the underlying mechanism of that dysfunction in channel, whether it's a gain with increased sodium current compared to the norm versus loss, blocked or impaired sodium current through channel, or complete disruption of protein function, or mixed with a complex loss of function, gain of function on electrophysiological readouts on functional studies. SCN2A, again, in the earliest forms with a straight gain of function, will present with early infantile epileptic encephalopathy. This is an infant with a tonic seizure, and you can see the EEG change with clinical posturing. And so these often, with the day of life 1, often almost look like a burst suppression pattern where you can look like you are in a medically induced coma, but you're not actually on medications, and that's due to the underlying genetic etiology when diagnosed early. Well, we know this. And so functional studies like dynamic action potential clamp studies predict functional variant separation in complex channelopathies and can inform therapeutic design. This is sorry about the formatting, but SCN2A is again expressed in the presynaptic hillock of axons. And you can see where these are many different forms of existing anti-seizure medications that do not address the underlying root cause, but do address symptoms of seizures as they propagate and affect at different channels. And so understanding the functional impact of a genetic variant is really critical for phenotyping and tailoring therapy for a patient and design of an approach. In clinical trial design, we discuss the markers for predefined measures that are individualized both to the patient and the disease. And so the concept of MCID, or minimal clinically important difference, or the smallest response, beneficial to the patient, which can lead to a change in the management plan, is an important concept that is to keep in mind as we do trial design. And identifying quantifiable, valid, and stable track measures, biomarkers, ideally in forms of target engagement when possible, but there's significant value in surrogate biomarkers as well as clinical biomarkers, and outcome assessments, including patient-reported outcome measures, can show significant value over time, as we've seen with some of the earlier slides, and I will show it today. Safety assessments, of course, in ASOs also include known risks, including hydrocephalus, which we're not seeing, but that we will follow over time also. Sorry about the formatting here, but allele-specific ASOs downregulate only the deleterious variant, and in this case, by recruitment of RNase H for decreased expression of the abnormal transcript, and so this is an allele-selective approach. So in this case, for the SCN2A patient that I'll discuss, over 500 ASOs were tested through in vitro screening to bind to the SCN2A pre-mRNA, and proof of concept data was obtained in participant-derived iPSC cells with tolerability and tox screen in rodent models, followed by GMP drug substance and project I'm so sorry about this formatting, but the point of this slide is to show that there's predefined individualized outcome measures that are based on the phenotype. And for this patient who is NL0001, his phenotype includes intractable epilepsy, severe developmental delay, nonverbal, non-ambulatory, dyskinesias, choreoathetosis, GI issues, and autism spectrum disorder. And so the tailored outcome measures for this patient are matched to the phenotype of the patient, including seizure frequency, following Bristol scale with autonomic and GI symptoms, the dyskinetic cerebral palsy functional impact scale, cognition across multiple measures, ataxia, and behavioral, and EEG was included as exploratory. This was approved by the FDA, and we've been in clinical trial since over the last year and a half. So this is a dosing schema that we started with the day, we began in 2024, March of this clinical trial for this patient, and the dosing strategy initially was first day 1 followed by day 28, then every 2 to 3 months thereafter. Initial findings from our safety and efficacy profiles, and we are in preprint that's accessible, show safety findings with no changes in CSF, stable findings there, and I have not seen any abnormalities on urine studies or otherwise in safety labs, as well as improvements across developmental measures, both in communication ability, seizure frequency. He hasn't had a seizure in several months now, and has not required a rescue medication. Previously was daily seizures. Also with a improvement in dyskinetic functional CP impact scale showing improvement or decrease in dyskinesias, which is also correlating with improvement in gait scales that we were initially not expecting to see, and subsequently included some amendments to the FDA to help support this. Lori showed this earlier, but I want to show it again because I have a follow-up video that, oops. Oh, let me go back. So this, oh, how do I do this? You saw this earlier. This was last year when we first started, and it was only 3 or 4 doses in. So he started at baseline, able to ambulate with a one-hand hold at best, significant dyskinesias that are obvious on video. And then he began taking steps after 3 weeks or so, and this was something that was unexpected. This was persisting daily for weeks with decreased movement. As we mentioned earlier, there was a bit of increase in ataxia and dyskinesias with inability to walk independently towards the 3rd month as we were getting close to the next dose. So this was actually as part of this, and this was similar to some of the other scales where we were seeing some recurrence of seizures towards the end of the dosing regimen. And so based on this, we submitted it to the FDA as an amendment with request for decreased dosing, interval to 60 days, which was authorized, and since then has been doing really well. This is a video from this last August in which he's been getting up by himself and walking independently. And this is also continuing to persist without a wear-off effect. And so this is a video at his grandparents' house recently, and I have many videos of this patient like this, walking around and doing well. And he's also, in terms of GI, has not needed any suppositories for the last couple of months as well. And so he's been really moving with intention. I'm seeing this across both in clinical and in the home state. And so this is a pathway we discussed from N of 1 to N of more. There's other children that we did identify on genomic sequencing that have a variant that's amenable to this ASO, and there's potential for these type of therapeutics. There is existing FDA approval we've seen across many diseases already precedented by Spinraza and Ionis initially, and the same concept bringing forward to N of 1. These targeted approaches really have specific potential for many monogenic neurological disorders, which includes the intractable epilepsies and the DEEs. And these individualized ASOs targeting different SCN2A variants are currently showing positive safety and efficacy data. The other SCN2A patient that was discussed has a different variant and a different ASO, and was able to wean off of phenytoin, which is a sodium channel blocker, and it really speaks to the underlying mechanism of action, even if there isn't currently a biomarker that shows a level evidence of target engagement. So this is an application of bridging variant identification with deep phenotyping to advance personalized medicine in channelopathies and more. Thank you.